morning, everyone, and welcome to today's webinar presentation, 2SLGBTQIA+ families, unique perinatal mental health concerns. My name is Sarah Carsley, and I'm an applied public health science specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin today's presentation, I would like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with the multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I'd like to acknowledge Daniel Coles, who helped co-author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio video has been disabled. The chat pod has also been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today's session, Dr. Susan Jack. Dr. Jack is a professor in the School of Nursing at McMaster University and the lead of the Public Health Nursing Practice Research and Education Program. Over to you, Susan.
Great. Good morning, everyone. Thank you very much, Sarah. I'm really excited to be joining everyone on this beautiful morning. It's sunny here in Guelph, so I hope it's a beautiful day wherever all of you find yourselves. And I'm really excited that we get to continue to expand our learning today and expand our understanding of connecting and collaborating with 2SLGBTQIA+ families within our work in Healthy Babies, Healthy Children. And today's focus really building on many of the concepts that we learned about last month. Our focus today will be on understanding unique mental health concerns of this population of families during the perinatal period. And so I am just really honored and so excited to welcome back our two speakers. And so Dr. Lori Ross, and Dr. Lori Ross is an associate professor in the Division of Social and Behavioral Health Sciences at the Dalai Lama School of Public Health at the University of Toronto. And her program of research focuses on understanding the mental health and service needs of marginalized populations to improve access to services for these communities. And also very excited to welcome back Dr. Zaf Andrade Romo, who is a medical doctor and a PhD candidate also in the department or in social and behavioral sciences in the Dalai Lama School of Public Health, also at the University of Toronto. And she has had an extensive career in Mexico as a physician, working in the area of LGBTQ+ health, including roles as the chief of the State Department of Reproductive Health in the state of Puebla, and as a public health researcher in the National Institute of Public Health of Mexico. And her current research focuses on exploring the role of autonomy in the mental health and well-being of LGBTQ+ women in Mexico using a Latin American feminisms approach. So Zaf and Lori, welcome back, and I turn it over to you.
Thank you so much for that introduction, Susan, and well, good morning, and thank you everyone for joining this second webinar. We're very grateful to be able to share today's topic with you. As Susan was mentioning, I am Dr. Zafiro Andrade Romo, and today I will be presenting alongside my amazing mentor, Dr. Lori Ross. So yeah, thank you once again for joining us. And before we begin our presentation, we'd like to include a disclaimer stating that this presentation was created by Lori and myself, and Public Health Ontario is neither the owner of this content nor responsible for its use. That said, I also want to start this presentation by acknowledging the land that I'm living, learning, and working on today, Turtle Island. And although I am a visitor, this land has made me feel not a stranger, but part of it. It has given me knowledge that has become an essential part of my healing journey, and it keeps giving me multiple opportunities to grow as a human being. I want to acknowledge that the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous people, which is where the University Family Housing now stand, which is where I'm currently right now. And I will also like to pay my respects to the past and present elders and knowledge keepers. And also throughout the presentation, we place 2S at the beginning of the acronym to recognize that Indigenous, sexual, and gender minority people were here in Turtle Island before settler LGBTQAI+ people. Since there may be new attendees, we will reintroduce ourselves and share a little bit more about who we are beside our credentials. So I go by Zafiro and I use she, her pronouns. I am an immigrant, but I call both Toronto and Mexico home. I consider myself a Latin American feminist, proudly identify as a lesbian, and I have been married to an amazing Mexican woman for 14 years. I am also aware that I'm a person with a light skin tone, and which has shaped my lived experience, including access to certain spaces and education. I also want to share that during my life, I've had different mental health concerns, and I have personal experience navigating perinatal care both in Canada and Mexico. So today's topic is also very personal. Lori, do you mind introducing yourself?
Yes, good morning, everyone. It's a pleasure to be here with you today. I'm going to start just with a brief visual description for purposes of accessibility. I'm a middle-aged white woman with long blonde hair. I'm wearing a gray top and dark framed glasses. I use she, her pronouns, and I grew up in rural southwestern Ontario on the very eastern edge of Treaty 29 territory. I now live here in Toronto on Treaty 13 territory, and I identify as a bisexual and queer cisgender woman. I have 2 kids, and I have both personal experience, but also many years professional experience researching perinatal care experiences of our communities. I'll turn it back over to Zach.
Thank you so much, Lori. And also in terms of describing myself today, I am wearing a black shirt with butterflies on it. I am also a short person. I have short hair. My skin is whiter, as I've mentioned, compared to many Mexican people. I'm in my living room and I have a parrot, a red parrot beside me. So continuing the presentation, here is our agenda for today. We're going to review one question that we didn't get to answer from the previous webinar. And then we will speak about the prevalence of perinatal mental health concerns, risk and protective factors, impact on partner or partners, and some supportive resources for your practice. We will also have some minutes at the end of the presentation for questions, so please write them in the chat. So this was a question from our previous webinar. Do you have any information about gender infant growth charts or intersex children and how to document this information? In terms of a deeper analysis to gender infant growth charts, there is a really good online talk called Pink and Blue, the Gendering of Pediatric Growth Charts by Dr. Amy Medeiros. And I will leave a link at the end of the talk so you can listen to it. Regarding intersex children and growth charts, it gets a little bit more complicated. I want to start by defining the term intersex. IGALI, a 2SLGBTQIA organization in Canada, has an intersex community hub, and they define intersex as a term that refers to a person whose chromosomal, hormonal, or anatomical sex characteristics fall outside the conventional classifications of male or female. And it is estimated that approximately 1.7 to 4% of the global population is born with intersex traits. Nevertheless, there is still a huge literature gap in terms of intersex people's health. And in Canada, we still have a lack of protective legislation, supportive infrastructure, research, and resources for intersex people. In part, this has to do with the ongoing history of medical violence and approaches to erase intersex people through medical and surgical interventions. So what about the answer to the question? Well, there's no specific intersex growth charts, and it's still not an easy answer. As soon as a baby or infant is diagnosed as intersex, at minimum standard, a clinical team of for the child should include specialists in pediatric endocrinology, urology, psychology, radiology, nursing, and in case of newborn infants, neonatology. In the case of an older child, an adolescent gynecologist. But what is more relevant in terms of intersex infant growth is to document each case using a trauma-informed case approach, which is something that we were speaking about last webinar, and we will speak about further in the presentation. Take time to understand the family and birth history, and not to focus necessarily on one chart that might cause more psychological damage than help, but to adapt the growth register to the needs of each child. And we wanted to start with the previous question because it also relates with today's topic. In terms of mental health and 2SLGBTQIA plus community, it is also essential to acknowledge that the historical harm and trauma that the medical and psychiatric field has caused, and we will speak further about it. So regarding perinatal mental health, there has been very limited research, mostly in countries like Canada, the US, and Australia, and from those most focused on lesbian and bisexual women. And the most recent studies have found that compared to their heterosexual peers, sexual minority women have different mental health concerns, including an elevated risk of adverse mental health and increased antidepressants use, increased stress during pregnancy, and elevated risk of depression. And also here on the slide, we can see the lesbian and the bisexual flags. Also, when we're trying to understand more about this topic, it is important to remember that the prevalence of mental health concerns is not the same for all sexual minority women. Consistently among studies, bisexual women appear to be at a higher risk for perinatal mental health concerns compared to lesbians. And I will speak further about some risk factors that might be contributing to this in the next slides. Also, postpartum sexual minority women are less likely to use antidepressants until their symptom severity is critical. Thus, a key takeaway for you as healthcare providers is that repeated mental health screening is recommended and very important in this population. So regarding transgender and non-binary people, the prevalence of perinatal mental health concerns is currently unknown. However, recent review articles have suggested that transgender and non-binary people may experience increased vulnerability to perinatal mental health concerns given higher rates of mental health challenges outside the perinatal period. And what we do know is that half or more than half of trans individuals experience depression during their lifetime, with much of it associated with discrimination and lack of support. Regarding two-spirit people, the prevalence of perinatal mental health concerns is also unknown. So we're seeing a gap here, right? We're seeing a pattern that needs to be researched. However, similar to trans people, we can also suggest that two-spirit people may experience increased vulnerability to perinatal mental health concerns, giving high rates of mental health challenges also outside the perinatal period. There's a survey by Transpulse Canada, a community-based survey of the health and well-being of trans and non-binary people in Canada, that found that regarding two-spirit people, 1 out of 2 people had unmet healthcare needs in the past year and identified themselves as a psychiatric survivor or a person with a mental health concern. And almost 1 out of 5 people did not have a primary healthcare provider. And we know that this can affect in terms of timely access to detection, treatment, and follow-up of mental health concerns. So what are some risk factors that contribute to a higher risk of perinatal mental health concerns in our population? Well, recent literature reviews demonstrate that in addition to stressors faced by the general population, 2SLGBTQIA+ people face discrimination, prejudice, cis-heteronormativity, transphobia, biphobia, and homophobia, which add layers of complexity to 2SLGBTQIA+ people's risk for perinatal mental health concerns. So, for example, in this slide, we are describing major risk factors in sexual minority women that have been described and identified at multiple levels. So at society level, sexual minority women might be experiencing different types of discrimination, barriers from the legal system, or lack of acknowledgement of the co-parent. At the interpersonal level, women might experience invisibility of their sexual identity, lack of social support from their peers or families of origin, and negative or harmful experiences with healthcare providers. And also at the individual level, the women might have a past mental health concerns history or also experience social isolation due to different factors. And all of these risk factors can contribute to chronic high levels of stress, depressive symptomatology, and anxiety, among other mental health concerns. Also, within sexual minority women, for bisexual women, distinct factors include lack of support, of social support and community, and experiences of invisibility. One example of invisibility and sexual identity-based discrimination is when bisexual women are assumed to be heterosexual when presenting to care with a male partner, and this invisibility may increase the risk for depression. And also, compared to lesbians, bisexual women have more risk of perinatal depression and lack of partner and family support. And this lack of support correlates with higher symptoms of depression and anxiety during pregnancy. So now I'm going to pass it to Lori for the next part of the presentation.
Thank you, Seth. Just move the slide here. Okay, so I'm going to move on to speaking about particular risk factors for trans and non-binary individuals. Just as a side note, I want to mention that we recognize that not everyone was at our last presentation, but in the interest of having enough time to cover all the material, we haven't defined some of the terms that we went into detail defining last time. So if you have questions about those terms, please feel free to put them in the Q&A, and we're happy to speak to them in the Q&A. So as I move on to talk about risk factors for trans and non-binary individuals, I just want to acknowledge that, as I mentioned earlier on, I identify as a cisgender woman. So I'm not speaking from lived experience here. I'm speaking from my experience, from the learnings that I've had through my own research, as well as the limited literature that exists about the perinatal experiences of trans and non-binary individuals. And so I recognize that there may well be trans and non-binary folks listening in today. And so I welcome and encourage you to share your expertise as well in the Q&A. So as Saf mentioned, we have very little research about the perinatal experiences of trans and non-binary people. And the studies that we do have focus very particularly on the experiences of transgender men or transmasculine people, generally folks who have retained reproductive organs that enable them to give birth. That's where most of the research in this area has focused. So as Saf mentioned, there are very significant knowledge gaps in this area. But we can offer you a little bit of an overview of what we do know so far from research. In order to talk about unique risk factors for trans and non-binary people, I need to talk about the concept of gender dysphoria. And I find gender dysphoria a complicated concept to define and talk about because I think that the medical definition of gender dysphoria has some problems. So I'm going to share that with you first and then talk about where I think the limitations are. So gender dysphoria from a biomedical perspective is defined as distress that occurs as a result of discordance between someone's gender identity and their experience of their biological sex. A couple of reasons why I feel like we need to just think critically about that definition. One is that gender dysphoria forms part of the DSM diagnosis that trans people are required to essentially meet in order to get access to publicly funded transition-related medical care. So there's a complex relationship between trans people and the diagnosis of gender dysphoria that we need to bear in mind, since it serves as a gatekeeping mechanism for accessing needed medical interventions. The other important thing to note about gender dysphoria is that that biomedical definition leaves out dysphoria that happens because not of an individual's feelings about their body, but because of how the social world responds to what other people or other institutions perceive as a disconnect between someone's gender identity and someone's physical sex characteristics. So that's really important to bear in mind too, as we move on to talk about how gender dysphoria becomes important for some trans and non-binary people. Another point I want to make about gender dysphoria is that it's not universal to all trans and non-binary people. Not all trans and non-binary people feel distress related to the relationship between their gender identity and their biological sex characteristics. And it's experienced differently by different trans and non-binary people. So there's no kind of universal experience of gender dysphoria. So having said that, those, I guess, qualifications around gender dysphoria, the literature does suggest that some trans and non-binary people experience gender dysphoria during the perinatal period for a few reasons. One is because of the way that folks' bodies change as a result of pregnancy, childbirth, postpartum, and nursing. And so some of those changes in terms of the ways that, for example, enlargement of breasts during pregnancy. A physical change like that that's associated with pregnancy for some trans and non-binary people can feel distressing because it may feel misaligned with their gender identity. The experience of birth itself and assumptions about reproductive organs as female, having to have genitals exposed in a public setting during the, well, not public, but feels public during the birth. Those things can also trigger gender dysphoria for some trans and non-binary people. And very importantly, another thing that can trigger gender dysphoria is use of incorrect pronouns or other acts of misgendering that happen in the context of receiving perinatal care or in the context of the birth itself. This is a very common experience for many trans and non-binary people who give birth. Our birthing systems are still largely set up to expect that every birthing person is a woman. And so assumptions that relate to that kind of expectation are common and result in people being referred to by pronouns that are not their correct pronouns or gendered language like ma'am or other kinds of gendered language. So those experiences are very important triggers of gender dysphoria that we need to bear in mind as well. So as I mentioned, there are limited studies, and we've listed some of them for you there. They'll appear in the reference list at the end of the talk. But those studies do suggest that trans and non-binary individuals who give birth may have increased vulnerability to birth trauma and perinatal mental health concerns. And I just want to clarify that when I'm talking about birth trauma in this context, I'm talking about the psychological experience of the birth as traumatic rather than physical trauma to the birthing person or the child that happens during childbirth. So there are a few factors that have been associated with this increased vulnerability. A major one is the experience of health care and care that doesn't consider the needs of transgender people, which, as I mentioned, our birthing spaces are still very much set up to expect and care for women who are birthing. And so for many trans people, there are multiple experiences through that process where their needs are not anticipated and often not met. Trans and non-binary people may also be at risk for these concerns as a result of social isolation, exclusion, invisibility, and lack of support, which, as discussed, are experienced by many trans and non-binary people outside of the perinatal period as well. And then finally, as I mentioned, gender dysphoria. I want to just briefly reintroduce the trauma-informed care approach. I'm not going to go into a lot of detail about this here since we spoke to it in more depth in our last webinar, but I just want to remind folks that experiences of discrimination, experiences of biphobia, transphobia, homophobia, these are experienced as trauma for many 2SLGBTQIA+ people. And for many 2SLGBTQIA+ people, these experiences are accumulated over the lifetime. And so they have a cumulative effect. And for many 2SLGBTQIA+ people, these experiences of trauma have happened in healthcare settings. And so whenever we're entering into healthcare settings, for many of us, there's some anticipatory fear there about what might happen. And so that is certainly very present in a context like childbirth, where there are lots of other kinds of fears that we're experiencing as well. So it's just important to recognize that these experiences of discrimination can be experienced themselves as trauma. And so as a result, a trauma-informed care approach is particularly important when we're thinking about providing care to 2SLGBTQIA+ people, and in particular, trans and non-binary people during the perinatal period. So what are the risk factors for the experience of traumatic birth experiences for trans and non-binary people? We've illustrated some of them for you here. So cis heteronormative assumptions and cis heteronormative healthcare settings. So the expectation that everyone who gives birth is a woman, and healthcare spaces that are set up with that expectation in mind. So for example, if there's a waiting room that has only a gendered women's washroom, that sends an implicit message that only women are expected to be using that space. Incorrect clinical documentation. It's important to recognize that people's names and pronouns may not be the same as what is reflected in legal documentation in terms of legal name and sex designation, for example, on a health card. And so that can lead to use of incorrect names in providing care. Misgendering, as we discussed, using the wrong pronouns or gendered language or the wrong name for someone. Refusal of services is something that does still happen for trans and non-binary people, particularly in trying to access services that are understood as gendered or only necessary or appropriate for one sex. Transphobia in healthcare settings, dismissive and unresponsive care, and all of these things together may really impact a trans and non-binary person's feeling of being able to advocate for themselves in the birth experience, which may lead them to experience a loss of choice or feelings of loss of control during the birth process. So these things collectively can contribute to risk for experience of traumatic birth experiences, which then in turn are associated with these mental health concerns. So we know in the general population as well that experiences of traumatic birth are associated with post-traumatic stress symptoms and disorder and with postpartum depression. For trans and non-binary people, they may be also associated with experiences of gender dysphoria, intense distress, as well as feelings of isolation, which can then in turn have impact on mental health in the perinatal period. In terms of non-binary individuals in particular, there's no research that we are aware of that has looked at perinatal mental health concerns among non-binary individuals in particular. Looking to research about non-binary individuals' mental health in the general population, so outside of the perinatal period, we find that in fact, non-binary individuals have poorer mental health outcomes than binary trans individuals. So in comparison to transgender men or transgender women. And so this has been attributed to experiences of high rates of discrimination and chronic stress due to experiences of invisibility. So it's important to recognize that non-binary individuals may be at particular risk in your practice and may also be particularly invisible in your research in your perinatal care practice. Similarly, for two-spirit individuals, as Zach mentioned, there are no studies that we're aware of that have looked particularly at the perinatal mental health of two-spirit people. We've drawn here from a study that I led a number of years ago now, where we did have some two-spirit participants. We did hear in that study about a lack of support and a very available resources for two-spirit parents during the perinatal period. So as this participant noted, there's nothing for two-spirit bisexual moms, not around here. And I don't think there's even a whole lot of people I'd go telling that to around here because they'd probably be calling Children's Aid Society on me. So just for context, this person lived in a very predominantly white suburb of Toronto. And I think it's important to draw out that that concern about bringing in Children's Aid, thinking about, the relationship between child welfare and Indigenous communities, beginning with residential schools and through the 60s Scoop, and the continued disproportionate involvement of the child welfare system in Indigenous children and youth's lives. And so just appreciating that there are particular, I would say, risks for two-spirit individuals in seeking out care related to any perinatal mental health concerns that they may be experiencing in the perinatal period. So turning now to protective factors for the 2SLGBTQIA+ community as a whole, many of the protective factors that we see in the literature parallel those that we see among cisgender heterosexual new parents, and particularly with respect to social support. Who that social support comes from might look a little bit different for some 2SLGBTQIA+ new parents relative to cisgender heterosexual parents. Many of us do have strained relationships with our families of origin and have built chosen families around us who may be the main providers of that support. So you may find that the social support networks may be a little bit more complex than you're used to with your cisgender heterosexual patients or clients. For gender minority people, the research suggests so far that the most important protective factor for folks' perinatal mental health is inclusive and affirming perinatal care experiences. And so this is actually wonderful news because it means that as providers, you have such an important role to play in supporting the perinatal mental health of your trans and non-binary clients. Simply by providing affirming care, affirming people's name, pronouns, gender, and working with them to ensure the best possible birth experience, being advocates for them when they need to enter into other settings where folks may not have the knowledge and skills in working with trans and non-binary people that you hopefully will have. I want to touch briefly on the experiences of partners, so the non-birthing parent or parents and co-parents. And there have only been a few studies actually that have looked at the perinatal mental health experiences of this group. It's a tiny amount of research compared to what we know about mental health among new heterosexual fathers in the perinatal period. So it's certainly an area where there's a lot of room for growth. But we've listed some of the important factors here. One of the key ones that we hear from non-birthing parents is worries and anxiety about the development of attachment and their relationship with their newborn, particularly if their partner is breastfeeding. There can be concerns about the extent to which they are able to also form attachments with their babies. For some folks who are a non-birthing parent, that hasn't been their choice. That has been the way their family needed to be formed because of experiences of infertility. And so there can also be feelings of grief and loss at the same time as feelings of joy about the new baby in their lives. Non-birthing parents in particular experience discrimination and invisibility in terms of a lack of social understanding of what their role is as a parent. And this is closely tied to legal issues related to potential lack of recognition as a legally acknowledged parent to their child, which I'm going to talk about more on the next slide. And then finally, we see that there are few services that are specifically set up to support non-birthing parents in the perinatal period. So a little bit more about legal recognition of non-birthing parents. It's important to know that birth registration is regulated by province or territory. So if you're situated here in Ontario, thankfully, we now have some of the most progressive legal parentage legislation anywhere. But if you're elsewhere in the country, the situation can be very different. And so in Ontario, a non-birthing parent can be legally recognized as a parent on the registration of live birth, but elsewhere that may not be the case. There are other provinces and territories where within a same-sex couple, a non-birthing parent cannot be recognized as a legal parent until a process of second parent adoption occurs, which is a time-consuming and expensive process. There are also issues around recognition of trans and non-binary parents, both birthing parents and non-birthing parents, in that the registration of live birth in only some locations includes gender-neutral parenting terms. In other places, the birthing parent is named as the mother only. And so clearly that excludes birthing parents who don't identify as mothers. And it's also important to understand that in Canada, legislation around marriage is completely separate from legislation around legal parentage. And so these two things are not actually related to one another. It makes no difference if a couple is legally married in terms of whether or not they both have access to recognition as legal parents of their child. So this is a huge issue, of course, in terms of the perinatal well-being of non-birthing parents in particular. So in some research that I led some time ago now, before the legal changes in Ontario, we heard from non-birthing parents that this was absolutely their major source of stress during the perinatal period, was that they could not be recognized as legal parents. And so if you think about, worst case scenario where medical decisions need to be made for the child shortly after birth, and the birthing parent is perhaps not in a position to make those decisions, the non-birthing parent, if not legally recognized, actually has no legal rights in that context. And so this is a huge source of stress for people that they don't necessarily have these rights in place from the time of birth. And of course, not being able to be recognized using the parenting terms that make sense for you and your gender can also be a huge source of stress for trans and non-binary. Okay, so just a couple of final notes before we wrap up and open it up for questions. It's really important to understand the historical relationship between 2SLGBTQIA+ communities and psychiatry and biomedical responses to mental health. So homosexuality was explicitly pathologized in the DSM until the 70s. And as I mentioned earlier, for trans people, there is still a complex relationship with psychiatry as an institution that is involved in gatekeeping access to gender-affirming care. So you may find that many 2SLGBTQIA+ people hold a lot of distrust towards biomedical interventions for mental health. And that comes out of this experience of a lot of harm that has been done to our communities through the institution of psychiatry. So it's important to just recognize and understand where that's coming from. It's not an irrational resistance, I guess I would say. It's that there have been real harms done and people fear more harm from engaging with psychiatric systems. Because of that, community supports and non-medical supports may be particularly important for 2SLGBTQIA+ people. Because of the way our mental health system is structured, where so much of mental health care is delivered through the private sector, this particularly impacts people who don't have access to the financial resources or extended health benefits that enable them to access mental health care in the private setting. So for those folks in particular, there's some work that's going to need to be done to connect them with resources that can meet their needs in ways that feel safe for them. So 2SLGBTQIA plus community support groups, particularly ones that are parenting specific, if you have access to those in your region, can be hugely supportive. And also being able to receive some care from you as someone who often is not attached to psychiatry specifically, may be a really important resource, or in cases where psychiatric intervention is ultimately necessary, having a trusted care provider who can help them work through that system may be very valuable and important. And finally, bringing it all together, the most important thing that you can do to support your 2S LGBTQIA plus clients through the perinatal period is through taking a trauma-informed care approach and a gender-affirming care approach, where you really recognize, acknowledge, and celebrate folks' identities and the particular strengths that they are bringing to their parenting as a result. So with that, I just want to acknowledge that a lot of the material we've shared with you today comes from a book chapter that Zaf and I wrote with two of our colleagues. This chapter is going to be coming out soon in the International Handbook of Perinatal Mental Disorders, I think is the title. Zaf can correct me if I'm wrong on that. So it's a forthcoming publication that I hope you will check out once it becomes available. And in the slides, which you will have access to, we've included a number of links and resources where you can go for more information. So here we've gathered together resources specifically related to mental health and some particular to perinatal mental health that we hope might be useful for you in your practice. And on this second slide, we've gathered together some of the key resources in the academic research literature that we've used to pull together this presentation for you. So I hope you'll find those things helpful. And with that, I just want to once again thank Susan and the team for having us today and doing such a fabulous job of supporting this webinar. And we look forward to taking your questions. Thank you.
Great. Thank you, Zaf. Thank you, Lori. And the questions are coming in, which is incredible. And we've had a few questions around I just want to let everyone know about the last webinar. We appreciate at Public Health Ontario, there's just a short bit of backlog, and we anticipate that probably, hopefully in the next month, the video recordings of all of our webinars since January, February, and March will be up on the website if they're not already there, because I've seen a few questions of those as well. And as you were both speaking, I'm just reminded and always struck by how much all of us as healthcare professionals or individuals who work with families in a variety of settings, that we must be mindful that for some individuals, coming into the healthcare system can be traumatic itself. And I often think in healthcare, and as individuals become a nurse or a physician or a social worker, we often hold a mindset that we are benevolent, good caregivers. And I do believe people go out in the world to provide good care to people, but we need to engage in our reflective practice and be really critical in understanding that the system as a whole, based on past experiences and assumptions and judgments, can be very unsafe for many people, and that we have a responsibility to really focus on, as you've identified, that trauma and violence informed approach to care, and really thinking about a safety for all approach. So thank you for that reminder to all of us. And I've been madly taking notes, but I'll get to the question. And the first three questions, and I'm not surprised at, is about screening and assessing for mental health. So within public health, particularly within Healthy Babies, Healthy Children Program and Nurse Family Partnership, the EPDS, the Edinburgh Postpartum Depression Scale, is the most commonly used assessment tool scale that's used in practice. So some of the questions are around that. So I'll read them to you and then let you chat about screening. So first one is, what screening tools are recommended for mental health screening, both for birth parents and the support parents? Then the second question is the EPDS appropriate to use? And the third one, then, I think will probably come up automatically, I think, in your response. Currently, the EPDS recommends specific different cutoff scores for persons who identify as men, and when validated EPDS tools in different languages are used, are there any considerations in the scoring of the EPDS when using with persons who identify as 2SLGBTQIA+? So screening and EPDS.
Sure. So Zach, maybe I can start and then turn it over to you if you have more to add. So these are great questions, and we don't know because there have been no research studies that actually have validated the EPDS against clinical diagnoses within 2SLGBTQIA+ populations. I have certainly used the EPDS in my own research with these populations, so I have found no difficulties in terms of people's responses to the scale. The scale scores look comparable to the scores that I see when I administer the scale among cisgender heterosexual women in terms of the distribution of scores, for example. So we so far have no reason to believe that there's any problem with using the EPDS within this population. And it is, as I said, the most widely used tool in research on perinatal mental health with this population. In terms of the cutoff scores, depending on someone's parenting role or gender, for example, we just don't know. And it's really complex because so there has been research, as the participant has rightly pointed out, that has established cutoff scores that are more appropriate for heterosexual fathers, for example. But within 2SLGBTQIA+ communities, ideas of gender are more complex than there being one cutoff that's appropriate for a cisgender heterosexual mother and a different cutoff that's appropriate for a cisgender heterosexual father. There are a lot of ways in which gender does not operate in neat, tidy categories like that within our 2SLGBTQIA+ communities. So I think we just have to use the idea of cutoff scores with some flexibility and really, look at how people are responding to the scale together with, their clinical presentation, with what they're sharing with you about the stressors in their lives. And also paying attention to specific items, right? So if folks are scoring on the final item about suicidal ideation, that then even if they're scoring 0 on everything else, that's something that you want to follow up and have further discussion about. So yeah, that I guess that the short answer is we don't know, but I would consider using the EPDS to be probably best practice at this time, as far as we know. Steph, feel free to add if there's anything you want to share there.
No, I agree. I think that from the literature review, that's the tool that we've found that has been used in the few studies out there and in different parts of the world. So yeah, that's the one that we would recommend. And also, like what Lori was saying, just be very thoughtful about each question, right? Because we already saw in the presentation that sexual minority women have higher some mental health concerns during the perinatal period. So definitely applying the instrument not only once or at the beginning, at the end, at the last visit, but multiple times during the care to the person, so you can compare how is it evolving and have multiple cutouts during the whole pregnancy and postpartum.
And just a quick question to add on, and Zaf, I was also recollecting one of your recommendations earlier in the presentations, where really reinforcing and endorsing this idea of asking, universal asking and asking early about mental health concerns. And again, if we think about the context of home visiting, do you have any wise words, either of you, particularly for nurses or midwives or social workers who might be new to these roles, of how, the language or how to introduce the idea of, now I'm going to ask about mental health? Typically, many public health nurses say, we ask these questions of everyone, because often the concern may be for someone on the other end as a client or an individual, sometimes there's a perception of, why are you asking me this? Am I like, do you think I have mental health concerns? Do you write that fear of already judgment? Any wise words of how that conversation can be initiated in a sensitive way, recognizing that there may be some increased risks or prevalence in the population?
Well, I think that it's very important what you're saying, Susan, on how not to make it like like a surveillance kind of thing, because people might be worried about like, why are you asking me this question? But definitely I feel that when you're asking about the family history of many other many other health issues, it's also like a good starting point to maybe ask about, are there any mental health concerns in your family, and have you had any mental health concerns during your life? This is important because I'm going to use this information for this and this. So giving a little bit more of explaining a little bit more, what are we going to do with that information? I also think that that gives a lot of reassurance to people. And yeah, that would be my answer. Lori, I don't know if you want to add some.
The only other thing I would add is, I think sometimes it can be really helpful to include in the conversation or in the ask something like, we know that the first weeks after a new baby are a really stressful time for a lot of people. To normalize that it's stressful, and that it's normal to experience some distress. And that's true during pregnancy too, right? If you're screening during pregnancy, to be able to say to people, for some people, pregnancy is a really difficult time. So I'm just going to check in with you about how you've been feeling emotionally through your pregnancy. And then that can just to help normalize and, like Seth said, kind of reduce those elements of surveillance that can be really stressful for people.
Oh my gosh, that's excellent. And I know my colleague Sonia is listening, and she's probably reading my mind of write down that script of what Lori just said, because I think that's really important as well of for working with anyone during these periods, sort of normalizing that this can be a stressful period of time for anyone, and that we be careful not to pathologize what might be normal stressors. So thank you for that language. Okay, I'm going to move on to I could talk to you all day with these great discussions. So the next question, for those of us who are mental health or healthcare professionals, are there any evidence-based psychotherapy models that have proven efficacy with the 2SLGBTQIA plus perinatal population?
So to my knowledge, not yet. So we expect that the same interventions that have been established for use in the general perinatal population are likely effective. I actually am working with a postdoctoral or a new investigator in the US right now who's working on doing some adaptation of an intervention specific to us LGBTQIA plus parents. So I'm hopeful that in the coming years, we will have more information about that. I've done some work outside of the perinatal period looking at structured mental health interventions, particularly CBT for 2S LGBTQIA plus people. And in our work, what we found there is that these tools, I mean, they're quite universally helpful. But it is helpful and important to think about how they can be adapted to address the 2S LGBTQIA specific context. So when we're thinking about CBT, for example, in understanding where some of these negative thoughts come from, it's really important to understand the context of societal homophobia, biphobia, transphobia, and early life experiences that people may have had related to that. So that social context needs to be there. And folks might need some support to help make those connections, but the tools themselves are probably really useful with this population as well. So what we really need is more evidence-based research to look at what kinds of adaptations are going to be necessary and important to make them optimally helpful.
Okay.
I don't know, Seth, if you have anything you want to add there.
No, great. Okay, thank you. And just one question around terminology. And Of the list of resources that you provided, which one of those resources would be most appropriate for someone wanting to learn more about the term two-spirit, or what would be a good resource for an individual wanting to learn more about the term two-spirit?
Sorry, yes, I was actually looking for the link for one of our resources, and like a whole glossary where people can find definitions about like different like two-spirit, trans, non-binary identities, so they can have more information. So I just
You'll put that in the chat, and maybe we'll make sure, Melissa, if we
yes.
open the chat, and if you could put that link in the chat. Excellent, thank you. Okay, here's someone saying, at our organization, we offer prenatal, postnatal education groups for people and their partners or support person. We have some participants who prefer female-only support people groups due to cultural norms and other reasons. So we have some groups that are female-only support people permitted, and some groups where all support people are welcome. So we have different options for people. Do you see any concerns with this practice?
Do you want me to start, Zap? And you can. So, okay, so the first thing I would say is that, like, the more options, the better. Choice is really important for folks to be able to address, the complex and diverse needs that we all bring into care. So choice is very important. Whenever you're doing anything that's gendered, for 2SLGBTQIA plus communities, it's going to be more complicated because we're going to have folks in our communities who don't identify as men or women. And so there's going to be questions sometimes about where folks fit or where is the right place to fit. The other thing to just be cautious about in that kind of context is policing around who counts as a woman, which is something that many trans women experience. As not being welcome in women-only spaces. So if you're offering a group that is a women-only group, it's really important to be clear and explicit about inclusion of trans women in that space, so that folks will know that they are also welcome there. Because that's the piece that gets tricky around a women-only space, is that many trans women have experienced a lot of exclusion from spaces designated as women-only. So that's the one thing that I would just offer a little bit of caution around. I don't know, Zaf, if you want to add there.
No, I agree with that point, Lori. I think it's the most important one. Be very inclusive in terms of trans women, because I think that with this webinars, what we've been trying to do is talking about affirmative and affirming practices for 2SLGBTQIA plus community. So we won't be able to say anything that be inclusive, be very clear about that this is a space for women, and that trans women are women. So yeah.
Great, thank you. Your point around choice, where we can build in choice, is so critical. Could you briefly, there was a mention of second parent adoption. Could you just provide a brief explanation of what that term is?
Yes, absolutely. So second parent adoption is the legal process whereby someone who's not legally recognized as a parent applies to become legally recognized as the child's parent. In Ontario, previous to the change in legislation, for a non-birthing parent to be legally recognized as their parent's child, they had to legally adopt that child, essentially. So it's not a legal process that's specific to that context. It's the legal process whenever you are legally adopting a child that is not your own, who also already has one legally recognized parent. But that's the legal recourse that non-birthing parents had and still have in some provinces and territories in order to become legally recognized as their child's parent. So of course that introduces a delay, it introduced costs, it requires access to legal knowledge and resources. So it was a really significant barrier for people in being able to become legally recognized as their child's parent. And certainly I know in Ontario, before the change in legislation, many non-birthing parents didn't go through that process because they just didn't have the means to do it.
Okay, excellent. Thank you. Okay, what are your thoughts on screening for individuals who may be impacted by gender dysphoria during their pregnancy for the first time? So they may not necessarily identify as 2SLGBTQI plus when initially presenting, but begin to struggle during pregnancy.
Seth, you want me to start that one? Yeah, so because pregnancy is just like such a hyper feminizing time, I appreciate that this may be a concern. I do want to say that because pregnancy involves a lot of preparation and complication for most trans and non-binary people, most trans and non-binary folks have done a lot of deep consideration about whether this is something that they want to do that they're comfortable with prior to kind of entering into the process. So I think the context in which it's coming up for the first time is going to be relatively unusual, but of course, can happen. So what I would suggest is that there's probably two important mechanisms for support. One is thinking about making sure the person is supported in terms of perinatal mental health, like what do they need in terms of addressing their mental health in the perinatal period. And the other is in terms of community support. So to make sure that they're getting support within 2SLGBTQIA plus community and community organizations around their gender and perhaps their evolving gender identity. Unfortunately, those two types of support are likely not going to happen in the same space, realistically speaking. So it's probably going to involve, multiple referrals or multiple sources of support to address both of those needs.
Great, thank you. And one last question, and I think I recognize this as one of my amazing colleagues who always asks me critical questions that just reflect her critical thinking. And deep thought about so many issues in public health. So she asked, to the point of categorization of people and the experience of gender dysphoria not being a universal experience, there seems to be a need to develop tools and screens that themselves are designed to be categorizing. For example, a focus tool just for 2S, or just for trans, or just for men, or just for women. What would be the advantage of these types of screens that are focusing on specific populations?
Oh, that's such an interesting question. And it's so complex, right? I mean, I guess like in an ideal world, we would have many screening tools that would account for the unique particularities of many different communities' experiences in the perinatal period. In the real world, it's just not going to be feasible or practical. Both because we just can't have 40 screening tools at the ready and have the capacity to know what those scores mean in any meaningful way, but also because we're intersectional beings, right? So are you going to give somebody the screening tool that's appropriate for them as a transmasculine person, or are you going to give them the screening tool that's appropriate for them as a newcomer to Canada? Like there's so many different intersections that we all embody that I think figuring out a particular screening tool for a particular person in a particular moment is just it's too complex for our measurement methods to be able to comprehend. So I think I would come back to the recommendation of using a universal tool like the EPDS, but using it flexibly and with your clinical expertise in hand to kind of interpret what those scores mean and think about what other additional questions you might need to ask given the particular person.
Oh my gosh. Well, thank you for that last answer. And as a researcher and someone very interested in clinical work and trauma and violence informed clinical approaches, there's so many tensions between the world of valid, reliable tools and measures and good clinical care where you sit side by side with someone and ask open-ended questions and listen reflectively. There's true tensions there, and I think we need to write and figure this out, right? So anyways, we're over time, but the questions were so critical. So on behalf of PHN Prep and Public Health Ontario, Zaf and Lori, thank you so much for sharing your knowledge and your experiences and your expertise. Thank you to everyone who joined. And in May, we will be having a webinar that will just be for the HBHC and NFP teams. We will be having a panel speaking about innovations in implementing PIPE. So I hope the Healthy Babies and NFP teams will join us then. So thank you again, and wishing everyone a lovely Wednesday. Take care and goodbye.